Hi, I'm Ralph Preston, and welcome to Stroke Buddies Tuesday support group meeting. We have these meetings every Tuesday, and we try and get them up on YouTube by Wednesday afternoon, so it's predictable. And if you can't make it here, you can find it hopefully at a certain time on Wednesday. Today, we're lucky to have Dr. Hetzler back with us again. He's going to do a presentation on spasticity. For those of you who missed his fabulous presentation on neuroplasticity, let me just say that he is a professor of psychology, and he taught for 43 years at Lawrence University. He went back after his stroke, and that involved a big old cognitive test, which he passed with flying colors, I believe are his words.
Yes.
And so he had a stroke himself. He had to take that test in order to go back to teaching. So I think he brings a unique perspective on this with not only the science, but the experience. So without further ado, I'm going to turn it over to Dr. Hetzler.
Well, thank you very much, Ralph. I appreciate the introduction. I was afraid you were going to say we had Professor Hetzler here a couple of weeks ago, and in spite of that, we're asking him back.
There's that smart aleck in you again. And we're glad that it came back after your stroke.
Yeah. Okay, I'm going to share my screen here, so I'm going to put the PowerPoint on.
Sure.
And then I'll start talking.
Okay.
There we go. I will be talking today about spasticity. I should point out at the outset that spasticity is seen in other conditions in addition to stroke. You see it in cerebral palsy and also in multiple sclerosis, for example. The topics I'll talk about include what is spasticity? Well, basically muscle stiffness, in particular in the anti-gravity muscles. From that, we'll go on to the Brunstrom stages of stroke recovery and the cause of spasticity and treatments for spasticity. If you have any questions, please feel free to ask during the presentation, or if you'd prefer, you can hold them till the end. At the end, there will be time for questions, but not time for answers. Here we go. In the United States each year, more than 795,000 people have a new or recurrent stroke. According to the National Stroke Association, around 2 in every 3 stroke survivors will have some form of disability. And stroke is the leading cause of disability among American adults. Muscle stiffness is often a common secondary effect of stroke. And this muscle stiffness, of course, is called spasticity. Spasticity mainly involves increased muscle tone in the anti-gravity muscles. These are the flexors in the arms and extensors in the legs. Now, if you think about this, gravity tends to pull you down, pulls your arms down and your legs down. So what muscle counteracts the effect of gravity in your arms? That would be the flexor. If you flex your arm, you're moving it upwards. And it is that muscle that is tightened during spasticity. On the other hand, gravity pulls your legs down. So gravity tends to try to make your legs flex, so you're closer to the floor. And you counteract that by extending your legs, so they're straight. Well, I appreciate that. I don't know. Sounds like someone was playing a hallelujah there or something. So flexors in the arms, extensors in the legs. Now, this slide shows the muscles, the extensor muscle and the flexor muscle at a joint. And in the left-hand panel, the limb is shown at an intermediate location. Now, when the extensor contracts in the middle diagram, you see that the limb extends. On the right-hand side, when the flexor contracts, the limb flexes. So to repeat what I said earlier, it is the flexors in the arm and extensors in the legs that are spastic following a stroke. So if you happen to have a cat that had a stroke, it would look like this. It would look like a stuffed cat in which all four limbs are rigidly extended. Because a cat has four legs. We will move on to the Brunstrom stages of stroke recovery. This stages model was developed by physical therapist Signe Brunstrom in the 1960s. And basically, the Brunstrom approach describes a sequence of motor development and reorganization of the brain after stroke. So here are the stages. Immediately after a stroke, the affected muscles become flaccid, that is, weak. Immediately after my stroke, I could not even hold a deck of cards in my left hand. It would fall out of my hand onto the floor. That's stage one. In stage two, spasticity appears. Now, as annoying as spasticity is, this is actually seen as a sign of recovery because your muscles are beginning to communicate with your brain. Then in stage three, the spasticity in the affected muscles increases. In stage four, spasticity starts to decrease. In stage five, spasticity continues to decrease. In stage six, spasticity disappears and normal coordination reappears. Stage seven, you're normal again. Of course, my wife would say I was never normal in the first place. But these are the Brunstrom stages. And this sequence is something that everyone would go through, according to Brunstrom. How long would you spend at each stage, and how long would it take to go through it? Well, that's hard to say. I know it's annoying when you talk to a physician or therapist and say, well, how long will it take me to get through it? And they'll say, every stroke is different. I used to be so annoyed when they said that. I said, well, give me some guidelines. Well, in one sense, every stroke is different. But the speed with which you go through this largely depends on you and how much effort you spend trying to get through it. So let's take a look at what causes muscle stiffness after stroke. Normally, your muscles and brain are in constant communication. They talk to one another. Your muscles tell the brain how much tension they're under, and the brain tells you how and when to move. When a stroke damages the areas of the brain that control movement, that impacts the brain's ability to communicate with the muscles. There are neuron pathways that go from the cerebral cortex, which I talked about in my last presentation, all the way down into the spinal cord with a synapse on the neurons that go out to the muscles. And because of damage to the cerebral cortex or the descending axons, and I know I haven't talked about the structure of a neuron or the components of a neuron, although I could in another talk. This affects your muscles' ability to protect themselves. So involuntary muscle contractions caused by damage to the brain are known as spasticity. In its milder forms, you may experience muscle stiffness, but in more severe forms, you may be unable to move. It may affect your mobility. Spasticity is often triggered by movement and is velocity dependent, which means that the more rapidly a muscle is stretched, the more severely it will contract. This is why, for example, if you have an affected leg and you're sitting in a chair, the physical therapist will pull your affected leg forward as quickly as possible to see how much resistance there is, how much spasticity kicks in. Not all spasticity is triggered by movement. Sometimes there's severe spasticity independent of movement, like when your hand is severely clenched in your right fist. The common signs of muscle stiffness, that is spasticity, after a stroke include limited range of motion, joint and muscle pain. Some patients complain of extreme pain from spasticity. There's rigid, awkward movements. You may have spasms or jerky movements, discomfort, difficulties with coordination, and the inability to voluntarily relax the muscles. And those muscles will stay contracted except for one time, and that is when you are in REM sleep. At night, when you fall asleep, you go through a series of stages. And one of those stages is called REM sleep. That stands for rapid eye movements. And that's when you dream. But also, your muscles are paralyzed during REM sleep. So you can't move them, meaning you cannot act out your dreams. And frankly, you don't want to act out your dreams. There is a syndrome called REM movement disorder in which people act out their dreams, and that can hurt them. There was one man, for example, that dreamt he was a linebacker attacking a running back, and he got out of bed and ran into his dresser. He was acting out his dream. Now, without effective management, spasticity can be, I'm becoming a verbal paraplegic here. Spasticity after stroke can progress into extreme tight muscles and joints, a condition called contracture. And basically, a contracture is generally viewed as a permanent shortening of ligaments and tendons. At that point, it becomes virtually impossible to move like a finger or a hand or part of a leg that has a contraction. So there are treatments for stiff muscles after a stroke. First, physical and occupational therapy exercises. We need physical and occupational therapists. They help us. And they can help you target specific muscles and practice exercises that will promote neuroplasticity and long-term spasticity relief. Key to reversing spasticity permanently is neuroplasticity, that is rewiring your brain. The more time you dedicate to trying to trigger neuroplasticity, the better off you will be at controlling your affected limbs. There are also range of motion stretching exercises. When you first start to treat spasticity, it's likely that your muscles will be very stiff. To help loosen them, you start with stretching exercises. Limber them up. Thank you. There is also constraint-induced movement therapy. This was devised by Edward Taub, who's at the University of Alabama in Birmingham. It was based on his earlier work with animals. One of his published papers was published in 2006. He studied patients with strokes that impaired the ability to use one arm and hand. He put the good arm, that is the unaffected one, in a sling for 14 days. Now, since then, the sling has been replaced with basically an oven mitt. So the good hand is put in an oven mitt, forcing the patients to use the impaired hand. This procedure is called constraint-induced movement therapy, or sometimes just CI therapy. A control group received cognitive, relaxation, and physical fitness exercises for the same amount of time. It turns out the constraint-induced movement therapy produced long-term improvement in the patient's ability to use the affected arm. That's shown here. The upper line shows the results from CI therapy, and the purple part shows how long they were in therapy and the improvement in the use of the affected hand. Then the follow-up is in the yellow part. As you can see, it persisted for up to a year later. On the other hand, the placebo control group did not improve at all. So this type of therapy is extremely effective. Knee extensions are very useful if you have spasticity in a leg. Again, the more repetitions you do, the more your brain will rewire itself and reduce your spasticity. You'll recover quickly this way because you're getting the brain on board. And that's the key. The purpose of the exercises is not really to affect the limbs, but the brain, because it's the brain that's controlling the limbs. And if you can increase the amount of brain area associated with that arm or hand or leg, then that arm or hand or leg will loosen up and you will reduce or eliminate your spasticity. Passive exercise is also useful. And especially at the outset following a stroke, you may need to use passive exercise. And in passive exercise, the limb is moving, but you're moving it with your good arm, or you're having a caregiver or a therapist move it. So the limb is moving, even though you are not using your brain to move it. And it turns out even extensive passive exercise will help rewire your brain and reduce spasticity. Electrical stimulation can also be useful. This involves the use of a so-called eStim machine that applies electric current to your affected muscles. That current helps move the muscle, and you can also feel it, and both of those things help wake up your brain, get it involved. Weight-bearing exercise is also useful. If you're able to straighten your arm or leg, that is the limb that has a spasticity, you can perform weight-bearing exercises. For example, if your arm is straight, you can put it on the top of a table and lean on it, applying weight. If your affected leg is straight, I think Ralph has a video of him standing on the affected leg. That's good as long as you hold on so you don't fall over. Again, this is about weight-bearing exercise. And this weight-bearing through the leg. Just walking is good, if it's safe for you to do so. Botox. Well, this can loosen you up. Botox blocks the release of the neurotransmitter acetylcholine. That's released from an axon ending. And I haven't talked about a neuromuscular junction, but I could in another lecture. And the acetylcholine causes the affected muscle to contract and your muscles to tighten. As Botox blocks the release of that neurotransmitter, that allows the affected muscle to relax. Now, the effects of Botox will wear off in 3 to 6 months, but this provides a window of opportunity for you to exercise the affected limb, be it the hand, the arm, or the leg. So Botox addresses the symptom of spasticity, not the problem, but while it's working, it allows you to use that limb. And the more you use it during that 3 to 6 window of opportunity, the better your arm or hand or leg will be when the effects wear off. Well, you can also get medication. And the main oral medication that is used is called Baclofen. This medication is usually taken orally, although you can get a pump surgically implanted in your spinal column that releases a continuous supply of Baclofen. Since Baclofen acts in the spinal cord, an intrathecal delivery system can be very effective. Now, what in the world does intrathecal mean? Well, I'm glad you asked that. Turns out the fluid-filled space around your spinal cord, actually, and brain, is called the subarachnoid or intrathecal space. And this space contains cerebrospinal fluid. Thank you. And the pump can administer Baclofen into the cerebrospinal fluid, and therefore you don't need to use nearly as much of it, about 1/300th of the amount of Baclofen that you would take orally. Now, I will show you what this subarachnoid space looks like. You're welcome. First, we have to understand that it involves the meninges. These are layers of tissue that cover and protect the brain and spinal cord. There are 3 layers. The outer layer is the dura mater. This is the toughest layer. About the thickness of one of those large rubber balls that are blown up and have a rubber band attached to them that you put over your middle finger and then punch the ball like that. The arachnoid is the next innermost layer, and it has the subarachnoid space or intrathecal area that's filled with cerebrospinal fluid. And finally, there's the pia mater. This is a thin layer that completely covers your brain and spinal cord. It's very thin and clear. It's like a covering of saran wrap all around your brain and spinal cord. What does this look like? Well, I'm glad you asked. That's what it looks like. You see the outer dura mater, and then the arachnoid membrane, and you can see the subarachnoid space that has blood vessels in it, and finally the thin pia mater, and below that is the brain or spinal cord. Now, I mentioned a Baclofen pump. The pump is a round metal device about the size of a hockey puck. It's surgically implanted beneath the skin of your abdomen and has a small plastic tube called a catheter that's surgically placed in the intrathecal space of your spine and connected to the pump. There's a reservoir in the pump that contains the medication. And in the lower right, you can see the pump, and you've got a catheter that goes into your spinal column to administer that into the cerebrospinal fluid. Now you have to be careful with oral Baclofen, because if you stop taking it suddenly, even if you miss a dose, this can cause withdrawal symptoms that include seizures. So you have to be very, very careful when using this and always take your dose. If you want to stop it or discontinue it, you have to talk to a physician. Don't do this on your own. Don't try to do it cold turkey, or you will deeply regret it. You basically gradually reduce the dose every 2 weeks.
For that.
How much you reduced it depends on your physician. So again, don't do this on your own.
Baclofen, talking about Baclofen.
I'm talking about Baclofen. Stiff muscles can also be treated with splints and orthotics. For example, if you have a clenched hand or foot drop, you may benefit from hand splints or ankle foot orthotics, AFOs. This is adaptive equipment. It doesn't address the root problem. It will not reduce or eliminate your spasticity, but it can improve your safety. The AFO can help you walk better. The hand splint can help straighten your fingers and perhaps allow for passive movement. So what do you do at each stage of the Brunstrom stage of recovery? Well, I'm glad you asked that. And I've outlined it here for you. Stage 1, flaccidity. Use mental practice. Imagine that you're using the limb. Also, passive range of motion. Either use your good arm to help you or have your caregiver or a therapist. In stage 2, keep trying to move the affected limb as much as possible and avoid learned non-use. Learned non-use basically involves the survivor relying too heavily on the good limb. So if your left hand is severely affected, you do everything with your right hand. Well, unfortunately, if you do that enough, your brain will completely forget how to use your left hand. It becomes a completely useless appendage. So you want to avoid non-use, and even though spasticity makes movement difficult, you've got to use the limb. Stage 3, you can use splints to prevent contractures, and you may consider taking Baclofen or have Botox injections, for example, in your hand. Stage 4, you feel good because spasticity begins to decrease. Wow, that's a sign of increased recovery. Again, keep using the limb. The more you use it, the better off you will be. E-stim can be very effective here in aiding in the decreasing of spasticity. Stage 5, spasticity continues to decrease. Here you might want to begin adding resistance to your movement. You use small 1 or 2 pound weights or a half-filled water bottle in your exercises. Stage 6, spasticity disappears, coordination reappears. Yes, you're almost normal. But you want to continue moving these muscles, continue to strengthen them, and begin using things that involves both sides of the body simultaneously, like golfing or shuffling cards. If there's something you used to do that you want to go back to doing, practice it, like playing the piano. Edward Taub talked about one patient whose left hand was severely affected by a stroke, and he exercised so much that he finally gave a piano concert, and his wife could not tell which hand was affected by the stroke. So you really do have to continue to practice. Main point is spasticity is treatable. It's treatable because it means your muscles are still trying to communicate with your brain. Your body hasn't given up, and neither should you. Eventually, your spasticity should start to improve for good. And for reading, I suggest you read the book Stronger After Stroke, now in its third edition by Peter Levine. You can buy this on Amazon. And I don't make any money off of this. But it's an excellent book to learn more about strokes and stroke recovery. And here is where I end the talk, but I'll be happy to answer any questions you may have.
Maybe you would unshare the screen and I'll switch the view back to everybody.
Yes. There you go.
Great. And let me go to view. Well, that works good. We can use a gallery view. I have a question that got asked to me, and maybe you can answer it. How would you know if you have learned non-use? I couldn't answer it. I kind of thought it might be obvious.
I don't think it's obvious, but basically, you can't use the limb. You just can't open your hand or you can't move your arm. It just hangs like a useless appendage. And you can't get your leg to move forward and walk. It's a useless appendage. It's attached to your body, but it's of no use to you at all.
Most stroke survivors will tell you that that's the state that they're in, you know, after their stroke, and some stay in that. I guess I thought this learned non-use was maybe a little further down the road.
Well, right after their stroke, they have flaccidity, where they've got weak muscles. But that doesn't mean you can't use them. And learned non-use occurs later on. It typically occurs after spasticity sets in.
I had a question, if I might.
Sure.
If you could help clarify for me the terms, I've heard spasticity versus tone. Are they one and the same? How are they different? I myself have movement of my affected side. I'm able to walk. I'm able to move my arm. I'm able to move my fingers. But I have resistance. I have spasms all along my right side. And I feel them all internally. And some days my fingers might be splayed. And today they're nice and relaxed. So what I need clarification on is when you were talking before about spasticity, how there's a beginning and then there can be a conclusion. Am I still experiencing spasticity? Am I experiencing tone? I'm not clear.
I understand. Normally, your muscles always have some type of muscle tone, and that's a state of contraction. Now, let's see, your left hand, for example, which is not affected by your stroke, has muscle tone. It's not like a wet noodle. It has a certain amount of contraction that's normal. Your muscles normally are held in a balance between excitation and inhibition. You have basically two pathways coming down to your spinal cord from your brain. And one excites the neurons in your spinal cord that go out to the muscle, and the other pathway inhibits those neurons in your spinal cord that go out to your muscle. And there's a normal balance there that gives your muscles a normal tone. And if you're trying to pick up something heavy, that tone will increase. You can pick it up. And that's because the brain is receiving feedback from your hand and sending the appropriate signals down. Now, that normal tone is disrupted in the case of a stroke. And basically, that descending inhibitory pathway that inhibits those motor neurons in your spinal cord is not being activated. And therefore, you just have the excitatory pathway, which causes an increase in tone called spasticity.
I see.
So to answer the other part of your question, yes, you're still in a state of spasticity. Those muscle spasms occur during spasticity.
Okay. And so,
but you can overcome that as best you can by using your right hand and right arm as much as possible. The more you use it, the more those spasms should subside.
so it's the brain's not communicating correctly, or it's overstimulating my right affected side.
Yes. Let's see, another way of putting it, this may make it more confused or more clear. Your cerebral cortex is sort of the top of your brain, and then you got the inside of your brain and a brain stem. And again, I can give another talk where I take you on a guided tour of your brain. But for right now, the point is you have one center in your brain stem. That's the start of the inhibitory pathway that goes down into your spinal cord, and synapses on those neurons in the spinal cord that go out to your muscle to relax the muscle. But that inhibitory pathway in the brainstem has to be turned on by an excitatory signal that starts in your cerebral cortex and goes down to the brainstem. And in the stroke, that cerebral cortex area, or the internal capsule, which is the descending axon pathway, gets damaged. So the inhibitory signals that start in the brainstem
Misfire.
are not turned on, and therefore the affected muscle does not receive that inhibitory signal, and you have an excess of excitation, which causes the spasticity. That might be a little confusing, but
It is a little bit, but I sort of follow what you're saying. I guess I'm 4.5 years in from my post-stroke, and in some respects, I'm finding that I'm getting more spasticity on my affected side as opposed to lessening. I don't know, obviously, if it has anything to do with any of us as to which part of the brain. Mine affected the thalamus, so that probably is part of what's making mine's spasticity stick around more.
well, not necessarily. I may have talked to you in the last.
You did.
Yeah, because I had my stroke in my thalamus as well. It can't say exactly it's that, but let's see. The thalamus has, going down right beside it, the structure I call the internal capsule. And those are axons that originate in the cerebral cortex, but the axons go down right past the thalamus into the brainstem.
There's like a tract.
Yes.
That's spiral.
Yes.
Some type
a pathway.
tract.
Yes.
Yeah.
And that can be damaged. That was true for me. I had a severe thalamic hemorrhage. In addition to the thalamus, it also damaged my internal capsule. And it was a damage to this descending motor pathway internal capsule that affected the left side of my body. So, but now also you mentioned 4 years out, you noticed an increase.
Yes.
If someone stops physical and occupational therapy or stops rehearsing, practicing using that limb, then typically people regress. That is, they go backwards in the Brunstrom stages. So you may have reached the point where spasticity was decreasing. If you stop exercising, then it can increase. Now, the only time that's not a problem is if you get back to normal. That is where the spasticity is completely gone, then you don't have to worry about it. But until that time, if you stop practicing, stop going to physical and occupational therapy, then you regress and your spasticity gets worse. And you have to go back to therapy or just practice more at home to improve again.
I guess maybe I need to rethink and listening to what you're saying, because I feel like from the time I had my stroke, I was, progressing, but in terms of spasticity, but then I hit a brick wall, and that brick wall has not changed in the last year and a half.
Well, that could be, but that just, again, I'm not a physical or occupational therapist, and I'm not a physician. So
I'm just, right.
But you have to change it up. Your brain responds to challenge.
Okay.
And if you've been doing the same exercises for 4 years, your brain says, oh, to hell with it, I'm tired of that. I want to take a nap. So you want to do different exercises.
Okay.
That'll help you overcome that plateau. Edward Taub described one patient whom we treated 40 years after his stroke and found successful recovery. So my
just to conclude my questioning, for those of us, all of us that have had a stroke have spasticity, but for those of us where it's affected the thalamus, does that complicate it? I mean, the fact that I'm having this extra amount of spasticity and I'm not able to push past it, partly maybe because what you're saying, and that's true. I have been doing the same exercises, and maybe I need to change that up. But my question is spasticity, when you've had a thalamus stroke, a different category than for those in general that have had a stroke?
It's not a different category. See, the thalamus has about 8 different nuclei in it, 8 different subareas. And it would depend on which of those was damaged. And also, if you also damaged a descending axon pathway that was next to the thalamus. It's hard for a person reading your CT scan or whatever to tell exactly what was damaged. Regardless of what was damaged, the only way to overcome it is exercise. And if you reach a plateau, you need to change the exercise.
Okay. So when I'm feeling all that resistance and, internal resistance inside my arm, where I feel like, like there's some muscle man in there that's twisting and turning my muscles, that is, that's something I still need to push through.
Yes, that is.
Okay. Okay. Thank you.
Sure.
Always fight it.
I have a question I'd like to ask, if you wouldn't mind.
No problem.
I've heard the term neuropathy thrown around in various contexts. Is that the same as spasticity? Is that a different type or subset?
Neuropathy is damage to neurons. So you often hear it in terms of peripheral neuropathy. For example, in diabetes, you can have damage to the nerves that leave your spinal cord and go to muscles or something. So neuropathy is damage to neurons.
Art, is that Art?
Yes, yes.
Hi, Art, this is Joanne.
Yes.
Okay, go ahead.
Yeah, I have very much the same issue as Joanne. Mine is on the left side, but I'm not getting spasms. I'm just getting tightness and a burning sense, but I seem to have full mobility all the way through, up and down, except I have loss of my peripheral vision all the way up because of my left side damage. So the question is, I'm very active. I go to a gym, I stretch, I walk. I'm even getting back to playing golf. So I've been forcing myself over the last 10 years to, after all the therapy that I've gone through over the first several years, to try to overcompensate and, you know, just live life regardless. But I don't feel it's getting any better at this particular point. And it's not pain, it's just discomfort that I have to live with. And you get used to it, and you know, you try to compensate in different areas, but it's a quality of life issue that you know, is very frustrating to experience.
I'm sure it is. And the discomfort is something that often is produced by spasticity. Now, you say you lost your outer field of vision in both eyes?
I believe, well, it's basically, I have no peripheral vision, period. So I don't know if it's in both eyes. It's neurological, but it's not the eyes.
Well, okay. So if you lost peripheral vision in both eyes, that's called bitemporal heteronomous hemianopsia.
Okay.
Great.
That doesn't help.
Can I write that down? Is that okay?
I don't care. Shit. You can write that down.
Art, can you repeat that 3 times?
No, I don't want to do that.
Yeah, that's why when Art and I used to, well, Art now lives in Florida and I live in New York, but we were all part of the same stroke group. And Art, we used to meet for our walks at the mall. And there was a point in time when Art would be walking and you didn't see a column of a wall, right? And you walked right into a wall.
I walked into a few things over the years. Yes. But Joanne would be doing her, you know, kind of movement, involuntary movement with her right hand, and I would be doing it with my left hand, which really went over big if we were eating dinner or lunch at a table. There would be stuff moving.
Exactly.
But you get that involuntary movement because you're trying to constantly, like your arm or side is fell asleep, and you always feel like you want to shake it. You know what I mean? Yeah. That's where but it's not a throbbing pain, maybe as Joanna, or spasms or anything. It's just, you know, you live with it, and I don't know how to unstretch it, you know, untighten it.
You just have to use it.
That's it. Okay. Mm-hmm. I mean, I did physical and occupational therapy extensively after the stroke, but you know, I am right here, and it's not going anywhere. But I'm trying to be as active as possible.
Good.
Hey, Dr. Hetzler, if I may ask a question specific to Botox.
Yes.
Now, you know, sometimes Botox is presented as, you know, the cure-all. Now, I would tell you that in my experience, and I've had 4 series of injections, and I got no relief at all. Is there any commonalities on where Botox, under what condition or what state works better than another? I mean, because it works well for some people get no relief from it, myself included. So is there any, in your experience, you know, you say, okay, you know, and I give my neurologist credit who administered the Botox. He told me up front, this is hit or miss. But in your experience, is there cases where it's more productive or more fruitful to try than others?
Well, again, I'm a sort of doctor that never helps anybody.
So that is so untrue. Just in this session and last, I've garnered some more understanding and knowledge. So you're
same here.
Okay, but
can I ask a question?
Well, wait. Let me answer the gentleman's question first. As far as Botox goes, if it's injected, it has to be injected in the general area where the neuron has, it's called a neuromuscular junction, but basically it's synapses with the muscle, because you want to reduce or eliminate the release of the acetylcholine that's released by the axon ending onto the muscle, and that causes the muscle to contract. So it's got to be injected in the right place. But I have heard that it does gradually lose its effectiveness. That is, over a series of months or years if you get these injections. And if it does work initially, you have to use that appendage repeatedly to change the brain. Botox is not going to do anything miraculous. It's going to make, let's say, your hand feel normal for 3 to 6 months, and then it'll wear off and it'll be right back to where you were before, unless you use that hand to exercise during the entire time, like for 3 hours a day, 7 days a week. If you're not willing to put in that time and effort, then the Botox is useless.
Okay, can I ask a question there?
Yeah, well, I got one thing to say before, if it's, and that is, I recently was, I know very little bit about this, but I'm going to throw it out there. I recently was chatting or reading about somebody who was getting Botox, and they were using some kind of imaging or something along with it in order to try and put it more in the correct place. I thought that was pretty interesting. And of course, when we get done with this call, I'll be looking up and trying to find out more about that method. But there was some.
That's what my doctor does.
Ultrasound.
Okay, Trish, go ahead. Tell us.
Yeah, my Botox doctor, he puts a thing on and it makes noise, but he can find exactly where he needs to put the Botox. And he also says, I'll tell you what, he says that I'm made the most progress out of any of his Botox patients ever, stroke patients, whatever. And he said it's because of all the hard work I put into it, is what he thinks. So you can't just get the Botox shot and,
Right.
But,
Right.
I mean, it's Can really I done ask a wonders question for me. on that?
I followed 5 people in a Botox study, and the people that did their homework got better. The people who didn't really. So I just want to repeat for everybody out there in YouTube land what Trish said. I do this occasionally. Okay, so if you don't put in the work, like, and Dr. Hetzler had said, up to like 3 hours a day, if you're not prepared to do the work, then you can't expect the results. In the groups, I see a lot of people who go, "Oh, I'm going to get Botox next week. Like everything will be fine," and it doesn't work that way. It's not a magic bullet.
Okay, on that, can I ask a question to follow through with that?
Sure.
I've got spasticity. I work 3 hours a day in the pool and everything. My question is, I have no pain or anything like that, so I don't go the Botox route. It is all natural. My question is when I start to work, when I work out, I do really well. I'm getting great results, but I got the plantar flexion going on in the bottom of my leg. My question is, and I'm bracing it. I got braces. Do you work through that? It doesn't hurt, but my toe will point hard. So when I'm doing exercises, for example, knee lifts, because I got everything, that's going on down there, the knee. And I do drills after drills after drills, riding the bike and all that stuff. But when it starts to get real pointed and it just won't release, do you stop or do you just work through that? Because that's what I have problems with. I mean, all of a sudden it will just kick in, and I've got great results, but and I don't know if I'm working too much, too long, too hard on it, need to rest it. I don't know where to go with it. Because it just points and it doesn't make me stop, and I do work through it. But is that a good thing, or is that not a good thing to just work through that pointing where you just can't get it released?
Hey guys, I apologize, but doctor, I want to go back because I don't think you've answered my question.
Oh,
I mean, I understand the work necessary afterwards, but is there any common traits or any commonalities on where Botox will work with an individual more so than another?
Botox.
I cannot answer that, and I'll get to the woman's
Her name
question.
was Jackie.
Thank you.
I cannot answer about which Botox injection site might work better or worse. Again, I'm not a physician and I'm not a physical or occupational therapist. You'd have to talk to the therapist and rely on their clinical experience. As far as the other woman goes, the question about the pointed toe, I've had no experience with that. I would say that that's something where a splint might help. I really don't know what to suggest. You could perhaps get a Botox injection to help that and then try to curl your toes and uncurl them. But I would think that a splint might be useful.
Okay, I do use the splint.
I get Botox for my toes because they were so curled up, bad curled up. And actually, they just started uncurling. So you can get Botox for your toes.
Yeah, I don't need Botox it's not curling. It's just that they don't move. My toes don't move. So
Toes don't move?
No.
So
and I'm working real.
Message me. I got something for you, some videos. I made my toes move again in front of the TV. The real solution here is, and Dr. Hetzler is doing his best job within his knowledge area, but what we really need to do, and I'm working on it, I have a physical therapist who had a stroke who I contacted a while ago. I talked to him yesterday about possibly appearing. I don't know whether he's neuro trained or not, but what we really need on here is for me to find somebody who's a neurodevelopment trained physical therapist, somebody who understands the neurological aspects and not just the physical therapy, somebody who approaches it from the brain and determines the exercise rather than gets out the book and says, you're hemiplegic, it says to do this. Right. And so I'm working on that. And, a lot of this knowledge goes across different disciplines like neuroscientists and physical therapists. There isn't any one human being walking around with all the answers, as hard as I try. It isn't me either.
Thank you.
But that's, basically to me, that seems to be the solution. Let's get somebody here with the expertise that we need. And trust me, I'm working on it. I'm working all the darn time.
Thank you so much for all your.
Thank you. Yeah.
Thank you.
Just, when you're only one person, you can only do so much.
Yeah, you're doing great.
But you do it well.
You do.
Well, thank you. I wasn't trying to solicit.
No, but it's true. Just by you putting this together and having the doctor be here to explain things to us. I think I've said it before, you don't always get the answers that you're happy with, but to me, knowledge is power.
It is. Dennis was a part of that. We talked on different subjects and it was focused to a degree, but we decided that it might be more useful to everybody. My whole point of doing this is to provide information. I learn stuff and then I can use it to help other stroke survivors. I'm in a maintenance mode on my recovery, and that's something we talk about sometime because Dr. Hetzler hinted on that today. You're kind of either going forward or you're going backwards. There's not really any, you don't float.
And I think also too, for all of us as human beings, you learn that in life, if you're feeling pain for whatever it is that you're doing, that's an indication that something is not right, so you shouldn't do it. But I think that you got to throw that out the window with stroke recovery. So maybe that's part of my issue is that when I'm doing my exercises and I'm finding that it's increasing my pain, then I'm thinking, oh, I must be doing something that's yeah, exactly. I hear that. I got it.
Oh, I always drink and I tip my glass upside down, try and remind everybody out there to hydrate. I didn't interrupt.
I have one observation about the timing of your presentation. Is it normal that this type of presentation, or at least explanation of the process, should be given by a neurologist and or a physical therapist prior to starting any regimen of therapy, so you understand where the end result is, like with the stages and all that? Because I don't recall having a definitive knowledge of all this at my point 10 years ago.
No, go ahead, Dr. Hetzler.
Well, that's a reasonable idea, but I doubt it'll ever be done.
Right.
I think the main thing the physical and occupational therapists want to do is get you into therapy, right, and get you started. I was after, I don't want to belabor my own stroke story. I mentioned that a bit last time, but
no, but it is helpful.
Yes, thank you. But when I came out of my drug-induced coma and my time in the intensive care unit, I was too weak for therapy, so I was sent to a nursing home for a month. Mm-hmm. And there they gradually tried to get therapy started. I was interested in knowledge that they didn't have, so I just worked on the therapy. And then when I was finally released later from the hospital, I started investigating. And this is a side note, and maybe I shouldn't even bring this up, but one of the first things I did when I got home was to look up all the medications I was taking and see if I wanted to keep taking them. And let's see, I guess I was on about 8 different prescribed medications. And I wanted to understand what they did, what the main effects were, and what the side effects were. Because all drugs have side effects. You have to tolerate the side effects in order to get the main effects. So for one of the drugs that I was on, I looked it up, and it turned out one possible side effect was permanent blindness. And I thought, well, damn, I'm not willing to take that. Go blind, I'll never go back to teaching. So I called the doctor and said, I'd like to stop taking this. And they said, okay.
Very cavalier.
Yeah, and I was put on a different one. Well, I'm glad I didn't keep taking it and go blind and then go, gee, I wish I'd stopped taking that damn drug. So you do want to be careful, and if you can, check out what they do and how they do it and why they do it.
You have to manage your own health.
Yes.
One of the things that I'm working on, kind of like a progression of the things that happen to you, what you need to know about them, how what you can do about them. And in the very first, I've broken into like 6 or maybe 7, I'm not sure yet, sections. In the first section, I call it What Happened. And one of the things that that I'm encouraging people to do, and I'm not sure how practical it is, it kind of plays into your thing, Dr. Hetzler. It'd be a great idea, but I'm not sure it's ever going to happen. And that is, I tell people to start learning everything you can about stroke. Everything you can. Well, first of all, right before that is find out, if you can, what caused your stroke and get it under control so you don't have another one. Mm-hmm. But then the very next thing, we're not very far into this progression, is, I want to plant the seed. Start trying to learn everything you can about your stroke. If it's thalamic, then learn about the thalamus. If it's brainstemmed and learn about the particular things. We have a guy in this group earlier who he had a cerebral stroke and he kept throwing up and he couldn't get an answer. He finally looked it up and found out that it's somewhat or fairly common with a cerebral stroke. I actually typed that to somebody yesterday because I learned it from him. So now we're back to Dennis's presentation on being your own best patient advocate. So one of the things that you need to do is gather all the information you can about your situation and about stroke in general. The problem is that at this early stage, you've just been, slapped to the floor, and you're worried about trying to get up, literally. And so I'm not sure what kind of attention or focus people in that, just getting whacked by the stroke, I don't know how able they are to deal with it. I remember I didn't have any place to get any answers, so and I felt kind of overwhelmed not knowing anything, and it was disturbing to me to not be able to get the answers that I wanted. I think if we went down to 20-something people that are here, everybody would agree to that. So that's my, if you're a newbie here at all, or no matter where you are, start trying to learn all you can about stroke and the brain and your particular situation.
That's the mission of a support group.
That's what? The purpose?
The mission of a support group.
Yeah, could be.
To do exactly as you're saying.
Well, and that's, so I'm running one, and we got people who have aphasia. We got people who don't have aphasia. We got people, with lots of different things. So you have to try and bring a mix of stuff, to so you can kind of bring something for everybody. However, this whole hemiplegia and spasticity and recovery thing happens to a big chunk of them. So that's why. I've been trying to hit some things that have the greatest common denominator, effective, or useful to the most amount of people.
I think that's very helpful, and I think that the doctor today gave a very good presentation and explaining a lot of the inner workings, and for that I think that's invaluable information. So thank you, Doctor.
Well,
you're welcome. I'm happy to.
Thank you.
And, we got a lot of confusion going on in the stroke groups. We tend to listen to each other a lot, which is good for certain things. I'm going to believe you if you try a device a lot more than I am going to believe the device manufacturer, because they got skin in the game. Okay, now you shouldn't be doing this with medical stuff. And one of the things that I noticed is back to spasticity and tone. There are a lot of stroke survivors who use those two terms
interchangeable.
And I'll have to admit to you that a couple of years ago, because of that, I thought they were interchangeable until I was talking to somebody and they went, no, there's a difference. And I looked it up and now I have an understanding of it. So, the support groups are great, but we can also kind of, confuse each other with when we don't understand, the differences or the proper medical terms. That's one thing that someone like Dr. Hetzler, and in this case specifically Dr. Hetzler, provided some good information that clears up the whole thing about spasticity. What I want to bring here is, okay, it does this, it doesn't do this. That's clarity. It does this and this and this. It doesn't do this and this. Now you understand. So
exactly.
And maybe we'll be lucky enough to get Dr. Hetzler to give us a tour of the brain or talk about learning centers or a few other things that he's more than qualified to do.
Yes.
I'll tell you, if we could all raise hands, everybody raise their hands to have you back, Dr. Hetzler. I can tell you.
Absolutely, 1,000%.
Yes.
Well, thank you so much. I'd be happy to. And as Ralph said, I've got 2 other talks that I prepared. One is language centers in the brain, and the other is called Stroke Overview, in which I talk about a number of things. I can give you a guided tour of your brain.
Excellent.
Also talk about things like Gerstmann syndrome, which you've probably never heard of. that involves damage to the left parietal lobe, in which you basically lose your ability to differentiate between your fingers. You can't tell one from the other.
Wow.
And you also lose the ability to do mathematics.
Wow.
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 It's interesting that we typically all learn mathematics using our fingers, except maybe
Right.
Ralph, who used his toes.
You
that's-
for multiplication.
Yeah, yeah.
Right.
Both
Taking a
feet.
beating, Ralph.
So that's because of what's going on in the left parietal lobe. And that's why you hear that the left hemisphere is good at mathematics, because of the damage caused in Gerstmann syndrome.
That's why I can still do complex multiplication in my head, because I had it right.
Right.
There's a lot of different things out there. One of my cousin had a stroke about a year after me, and there's supposedly, you would know more about this than me, but there are apparently 6 centers in the brain that are responsible for facial recognition, and they also deal with map reading and orientation. And he, after his stroke, he had a lot of trouble. He didn't recognize friends and family. He could see the image and couldn't connect to the memories in the brain. He actually went through a study in British Columbia. It was part of a group, and he had 2 or 3 of those areas damaged, and they actually taught him how to use the ones that weren't damaged in a more effective way.
Interesting.
Wow.
The British neurologist Oliver Sacks, he's deceased now, but he has a book called The Man Who Mistook His Wife for a Hat. And
I'm not touching that.
Catchy title.
And so he talks about various patients in that book, and one of them could not tell people by their face. And he talks about the areas of the brain damaged. And by the way, in that book, he also points out that left and right hemisphere strokes are equally common. And as he said, why wouldn't they be?
Right.
But he said, you have far more reports of left hemisphere strokes than right hemisphere strokes, because the effects are more salient following left hemisphere strokes.
Interesting.
But also in terms of, in my guided tour of the brain, I talk about some of those areas, Ralph, that you were just talking about. One is the hippocampus, which is on the underside of the temporal lobe in each hemisphere. And it's involved in the formation of new memories. So what did the hippocampus say in his retirement speech? Thanks for the memories.
He had a stroke and even remembers his corny jokes.
Right.
No cognitive damage. I'll swear to no cognitive damage on that stroke.
Bada boom, bada boom.
All right. Well, that seems like we've been going a good amount of time. That seems like a good breaking point. Unless anybody's got another question or issue that like to see addressed. Okay. Well, once again, thank you so much. I learned a lot. The point
Yes, definitely.
I try to learn.
So did we, yes.
I try and learn this stuff, not so much for my recovery, but the more I know about recovery, the more I can help somebody else. And knowledge, as Joanne said, knowledge is power. And I want to thank you for giving us some more of your knowledge today. And
Yes, thank you, Doc.
Thank
Thank
you,
you.
thank you, thank you.
And I appreciate all of you spending your time to hear me talk.
No.
Nice of you. Thanks for attending, and hopefully we'll meet again in the not too distant future.
Yes.
Okay,
you.
thank you so
Thank
much.
you.
Bye-bye.